Okay, I guess we should get started. We got a good mass. We got 52 participants, and it's 6:04, so might as well. This is something of critical importance. So let's get rolling. Good evening, everybody. My name is Hamid Khan. I am with the Stop LAPD Spying Coalition. Welcome to our webinar series, Power Not Paranoia, and this is part 5 of the webinar. We started this series on March 31st in light of what we saw as how police powers and the police state expands during times of crisis, both real and concocted. And I use the word concocted in a sense where there's been several crises that have been just created just for the police power and the police state to expand. We've had webinars on community health before. We had one on gender and sexuality, on the impact on sex workers. We had one on the war on youth last Tuesday. And then we also did one with Andrea Ritchie and Kath Rogers from National Lawyers Guild on policing. And today, as we are moving into this phase of how things are moving and the situation remains extremely fluid, we have to acknowledge that, and so we want to really just do a deep dive into what is happening out on the ground and what sort of roadmap to recovery is being suggested. We are hearing all these terms like syndromic surveillance, serological surveillance, sentinel surveillance, contact tracing. And for many of us, this is something that, is the first time that we are hearing this. So we've got a really awesome group of folks, both from a public health background, who are researchers, who are academics, who teach this thing, but also take a more radical view of things and very much converge and in line with the way we look at these things politically and critically as well. We also have folks who are direct service providers on the front line of healthcare, and also folks who are just out there in the community 24/7 looking at the impact on the community. So I'll just do a quick round of intro, and without just spending too much time, because we have with us Professor Bita Amani, who's a professor at Charles Drew University of Public Health and epidemiologist, and is also the co-chair of the COVID-19 Task Force on Race and Equity at UCLA. We also have our very own Jamie Garcia, who's a registered nurse in Boyle Heights and also an organizer with Stop LAPD Spying Coalition. Of course, my brother from another mother, Pete White, just our community leader in Los Angeles, but also somebody who's got the pulse of the community and really a community which is one of the most vulnerable communities in the United States. So we have folks, and then we have with us a group of folks who we have Harry. Let me just pull up that information. Where did it go? Okay, let me just see this real quick. Yes, there it is. So we have Jen Alvarez, who is, Jennifer is a Master of Public Health candidate with an emphasis on urban health disparities as Charles Drew University. We also have Harry Hudson, who's a scholar, and they're an academic laborer at USC in Cinema and Media Studies, and also have Meena Sharif, who's a postdoc researcher at the Center for Study of Racism, Social Justice, and Health at UCLA, who studies the impact of structural inequities on health and well-being across the life course. So we got a really awesome group of folks, so let's make the best of it and see. The idea is for us to really get to understand what's going on as of right now at 6:08 in Los Angeles and around the country, and what is our defense, what is the impact looking like, and what is our response in a time of crisis like this. So just a logistical piece. So Shakir Rahman is a co-host. So Shakir and myself would be sort of managing the sound and everything else. Unfortunately, we cannot unmute everybody, so we are controlling it. Yeah, we hate to be policing people, but because of the recent Zoom bombing and everything else that has been going on, we've also disabled the annotation piece as well, so people are not going to be drawing stuff on the screen. And as far as the screen share is concerned, it's also Shakir and myself would be controlling it in case if we want to show a PowerPoint and all. So my apologies because obviously we are here for abolition of policing, and here we are policing ourselves, but in the interest to keep this, to avoid any untoward incident, that's what we are doing. If you have any questions or comments, please post them in the group chat right here, and so we can at least keep a tab of that. And when we get to this, and then if you're on the phone, I'll give you my personal cell phone number, which is 562-230-4578. It's 562-230-4578 in case if you want to send a text with a question or a comment. And then once we've had this conversation for about 45 minutes or so, then we'll see if we can unmute everybody or see how that'll work to unmute all the participants, because we want to spend a good hour to have a collective conversation. So let's get right into it. So I'm going to just go to Bita, Pete, and Jamie to start off with. Just very briefly, if you guys can give us, from your own vantage point, that what do you see on the ground right now? So what is something that we should be knowing from your vantage point as to what's going on? Anybody, Bita, you want to start?
Okay, I mean, I think that from a public health perspective, we continue to still see like the run for the numbers, right? A lot has happened just in the last like 36, 48 hours in terms of studies that have been published, and another group of people coming out right after that saying, hey, there's something wrong with those numbers, or those numbers can't be interpreted without context. We've seen increase in cases, and people are saying, we have increase in cases because of the fact that more people are testing and more testing is becoming available. And so we still have, this sense that the epidemiology is evolving, right? So the patterns of the disease are still evolving. We are still committed to the idea that it's infectious, that it is not something that we have seen before. We are a lot more optimistic on how many people what we're calling the case fatality rate, so how many people are going to die from it. But then we're also now kind of, both scared and scaring folks that there is this idea that more people had it than not. And because so many people have it that don't know it, and it's something that can be easily transmitted, that there's more of a, that there's more risk than we originally anticipated. And so I think for the purposes of the coalition, and what our role is here, we continue to see this idea that these numbers can both be used either to support one policy, and the very same numbers can be used to support another policy. And so, we're here, given this kind of like mess that we are in, to think through what the impacts of all that are. And then what we do know, though, within all of this is that if you look at like within what they're calling the racial disparities within it, that the people who are dying, so if we just put our minds outside of the testing and who has it, who's getting diagnosed and all that, if we look at the people who are dying, we know that for sure a lot more Black lives are being lost, a lot more Latino, Latinx lives are being lost, as well as Indigenous lives. And so this is, I think this is what we know. And that structural racism is the root of it, no matter what they say.
Thank you. Thank you. Pete, you want to just, from your vantage point, share some of your thoughts too? And let me just see if I can mute you, or try to unmute yourself. Oh, there you go.
Yeah, can you hear me?
Yes.
So I think I'm just going to pick up on a couple of the last things that Bita said. Very clearly, structural and institutional racism, I don't know why I can't get words out right now, are glaring and show the root causes of who lives and who dies. And this is going to be consistent, just as consistent in Los Angeles as it is in Atlanta, New Orleans, Detroit, St. Louis, and all of the other places where Black people are dying en masse. It's been really interesting in Skid Row because we've been out on the streets doing mutual aid work for the past 6 weeks. And it's just been a continuation of the organized abandonment that has always faced that community. So there's been no tests. There's been, I mean, basic public health infrastructure, the same sort of dirty divide infrastructure that we've been fighting for a decade, is still being placed out in such a manner that it's more for show and tell and not at all to hold back this disease. And we've had to sort of deploy our own sanitation stations and public health infrastructure. The other thing that's been really interesting for the purposes of this conversation, there's very clearly a containment strategy. So we see more patrols, more LAPD patrol now, and it really feels like a carceral, not that it didn't already feel like a carceral community, but even more so now. You have, you know, every minute, every 2 minutes, LAPD just rolling around, rubbernecking, and not rubbernecking and looking at folks trying to discern if someone needs help. No, not that at all, but really how to keep folks in the cage. And then the last little piece I'll just say, we had one of our core members who's an artist and who's been throwing down and on the mutual aid front, got really sick yesterday. That was yesterday. All these days come together. And so we called the paramedic for this artist. The paramedic came. The paramedic touched the artist's forehead, never took the temperature until we said, yo, wait a second. Why don't you, at a minimum, take this person's temperature? Because isn't that one of the symptoms? And so even in the height of a crisis, even in the height of a pandemic, this person had been going in and out of consciousness. The response that we got from paramedics was subpar. They didn't, for this conversation, they didn't give a fuck, right, at all. And had we not been there to advocate, had we not been there to push, they wouldn't have even taken this person's temperature. So that's where we're at, and that's what we're seeing from the front lines, and that's where we'll continue fighting from.
Yeah, that incident, Pete, I happened to be, this was right after we did the food distribution, and just the apartheid type response was absolutely tragic, and you know, the failure of the system constantly. But you know, maybe from our vantage point, but it really works for the apartheid system. So that's how it's set up for that. Jamie, any thoughts from where you're at?
Hi, everyone. Like Hamid said, I am a registered nurse and I do work in acute care in the hospital in Boyle Heights. I think for me, one of the key things about what's happening right now is there's constantly in the media this term that we are in a crisis, in a healthcare crisis, where I think if you speak to a lot of nurses, they will tell you that we've always been in crisis. There's not one day that a nurse works a 12.5-hour shift and gets 30 minutes to sit down and eat, and that's primarily all she gets to do as far as resting. Maybe uses the bathroom once during her shift because the resources have never been there, because we don't have the time and the luxury of time to not be running from one crisis to another, from one room to another and doing things. So I think this whole notion of healthcare crisis needs to be seen in the context of history, that we've always been there and now we have a pandemic. So that keeps, you keep hearing that in the media, and it really is kind of almost insulting to people who have been under that pressure for the entirety of their career. But as far as protective equipment, we're still in the same boat that we've been in, where it's limited. It's not, for example, it gets rationed out. Sometimes nurses have to sign out for it. You can't automatically request a mask. You can't automatically get a face shield. You have to sign for it. They have everything accounted for. But things are constantly changing. So every day I go in, there's something new. And I think it has a lot to do with, as Bita was talking about, as we're learning more and more about the virus, one of the biggest things that's throwing everybody off is this asymptomatic transmission. So what's happening in the hospital is that people are, who have come in, living in different areas, being in different places for different reasons, are being found either through contact tracers or are later developing symptoms in the hospital. and are exposing units that are not COVID units. So, and I mean that in the sense that most hospitals have people who are positive in certain areas so that nurses are prepared and can use protective equipment to actually treat patients. But now, because of asymptomatic spread, because lack of testing, we're seeing a lot of people, we're seeing cases of people slipping through and nurses not having the equipment they're supposed to have to treat someone who is positive. So that's been something that's been, that now even California has become the first state to come forward. And this is just something that I saw immediately, like right before we got on this Zoom meeting, that we're one of the first states that are now saying, you know, oh, maybe we should be opening up testing to people who are asymptomatic. And I think we're going to kind of go through what does test, track, and quarantine mean, because that is those catchphrases they're using, and they seem very familiar to contain, control, and criminalize, which the coalition often speaks about. But lastly, I think one of the things that, thinking about it today, that I've been noticing more and more and have become more and more inspired as a healthcare worker within the system, and within a culture that I have to say, you know, we speak about structural racism, and it's definitely in the healthcare system. It's definitely a part of a lot of people's mentality in healthcare. Sometimes, you know, where you're shaking your head and you can't believe this person is an actual healthcare provider with things that are coming out of people's mouths. But what I'm also seeing that's like counter to that is this solidarity that's starting to happen. You see nurses, I think one of the coolest pictures I saw was a nurse. We've seen a lot of these fascist protesters saying, open up America, you know, don't tread on me, and out there saying that coronavirus is a hoax. And you've been seeing nurses actually in scrubs with face masks on, actually blocking protesters, blocking cars. And so that kind of solidarity has been amazing. We've seen nurses today out in St. John's, nurses through I think it's the National Nurses Association protesting for more personal protective equipment for nurses. And lastly today, I think the one thing that really was kind of just phenomenal was you saw nurses and healthcare workers from LA County Hospital actually promoting and demanding the release of our people from prisons. Mm-hmm. So that type of solidarity that I'm seeing is just so refreshing, because oftentimes it's a lonely road in healthcare when you are, you know, speaking of abolition and you're trying to convince your coworkers as to why abolition is necessary. So those are some really, really positive things that I'm seeing now.
Thank you. Thank you. And just while we are on a positive note for today, I also want to take a moment to honor a lot of work folks who are on this as well, that today the dismantlement of predictive policing in LAPD is complete. So they announced that Pret Poll will be discontinued, which really is amazing work. And I want to honor Jamie's work as a core leader for our lead organizer for the data-driven policing piece. So awesome. It's interesting that Moore, the chief, talked about budgetary constraint, but just last year in March, when the Inspector General audit came out, it said that LAPD has never even paid for that program. So it's like, of course, they would never, you know, and we don't expect them to credit the power of the community, but it's really the power that was built by folks in Skid Row, at LA Can, at Black Lives Matter, at White People for Black Lives, at Free Rads, our partners who helped us in really developing it graphically as well. So power to the people. Thank you. So let me just go now as to, I mean, Jamie, you talked about the test, track, trace, and quarantine, and you know what sort of roadmap is being suggested, and we hear all these terminologies. So let me just open up, because there's a PowerPoint that our team has also created too. But before I do that, I need to go to Harry's mic, because I'm going to have to do it. Let's see. Okay, do you want to unmute yourself? Because every time you mute, I have to go and unmute. Yeah. So let me go there and open this up. And let's start from the beginning. Okay, so let's go. So who wants to who from the team is going to be walking us through some of these slides? I know it's a joint effort, so.
I'll take the first two, Hamid, right now, because the first two
Oh,
are.
yes, your name is right there.
Yeah. So hey everyone, really excited to talk about all this different expansion of the public healthcare surveillance system, and I think this is a really important example of what we mean and what the coalition has always meant by the stalker state, in the sense that there's systemically there are systems that are collecting data from us, exchanging this data. And it's really important for us to explore and to understand that even though healthcare is the solution we're looking for, that public health is also very much complicit in this, in the stalker state. And so today, the point of today is to unpack that, is to look at healthcare's complicity in that and in the context of COVID, and what does it mean to us, and what are the solutions to fight back? What are the solutions to expose that? So an overview of what we're going to be doing is we're going to be looking at these various types of surveillance tools that are being talked about. We're going to focus on contact tracing today, but we're also going to mention what syndromic surveillance is, serological testing, and sentinel surveillance. We're also going to go into the history of contact tracing, talk a little bit about what the public narrative is around contact tracing, and then we'll discuss briefly what the roadmap to reopening America is, who is creating this roadmap, who are they partnering with, and how is it reflected in the local state and county systems. And then we'll open it up to have a discussion with the community about what does all this mean, what does it make us think, what ways do we need to defend ourselves. So I wanted to just start briefly by talking about, I'm not sure, or maybe many people have been staying up to date with Gavin Newsom's, the governor of California's, press briefings that he has on a daily basis. But April 14th was a key day where the actual speaking about reopening areas in California was had. And he, at that time, he mentioned six key points that need to be fulfilled in order for certain places in California to start opening up. And so we're looking at things locally, countywide. And so these are the steps, and this is the advice that he's giving to folks. So of course, the first one is to increase test and implement contact tracing. And that they kind of, put that in one little liner and just kind of say it. And there is so much to unpack in just that. The second point was to care for vulnerable communities, looking at folks with disabilities, those who are incarcerated, and those with comorbidities. And comorbidity means if someone has hypertension, diabetes, and these other healthcare conditions, that care for vulnerable populations need to happen. And of course, I think many are on this Zoom call realizing that this is long overdue. And like I said, there's always been a healthcare crisis. So care for vulnerable populations has always been needed. And then managing surges in hospitals, making sure we have appropriate beds, PPE, and ventilators. Work with public and private and academic partnerships to discover therapeutic treatments, which mostly means that they want to find a way, because we don't have a vaccine right now, they want to find a way to treat COVID and to actually have people live through it, so that we're not seeing people actually die if they contract COVID, so that there's ways to actually treat it and that you recover from having the illness. Lastly, to support physical distancing in public places like businesses and schools. And this one I really want people to focus on as we're doing the whole presentation, because what we have to start to imagine is, what is our landscape going to look like now when physical distancing has to happen? Are restaurants going to have, thermometers and take our temperature every time we go into them? Will there be surveillance, drones, seeing if certain areas have fevers, monitoring for fevers? What is the new going out in public going to look like? And then at the end, and this for folks who have been a part of the data-driven policing fight, of course, it goes back down to data-driven results that dictate where we can go, if we can continue in reopening, or if we have to go back to stay-at-home orders. And so I think part of this, and Bita touched on it a little bit, is that there's a lot of confusion in the numbers, and our numbers really what is going to bring us to a solution or to a resolution to this pandemic.
Okay.
Okay. Hi, everyone. Can you all hear me?
Yes.
Okay. So just to echo off Jamie, that today the Governor Newsom, he announced the expanding of training to further these surveillance tools that I'm going to go over. Specifically, he does talk about contact tracing and serologic testing. So I'm going to explain them. These surveillance tools, they're either passively or actively moving information of confirmed cases. So when I talk about passive, I'm referring to reporting and giving of information at a local database level, and then it can be channeled to other databases at state, federal, and global levels. And when it's active, it's the search. It's actively searching for cases to pull information from and send it out. So when we look at Sentinel Surveillance, this is targeted passive surveillance at selected locations like clinics, hospitals, labs, and they share the reports of cases and diseases to agencies like the local public health department, which then reports to the CDC, and then can be obliged to reporting it to the World Health Organization. When we look at syndromic surveillance, this attempts to identify illness clusters early through syndromic indicators before any diagnosis has been confirmed or reported to public health agencies. And this is to mobilize a rapid response. Certain programs monitor surrogate data resources, sources that can track your over-the-counter prescription sales, or if you were absent from school or work. All of those are not disease-specific syndromes, but they're part of the databases that feed into the syndromic surveillance. So then when we look at serologic testing, it's looking to identify reliable markers of immunity to a virus to measure community exposure. So this is something that's being expanded on right now, and new serologic testing is like a quick finger prick to capture if you had the virus, but were not asymptomatic or you were never tested. So we're going to be focusing more on contact tracing, which is active surveillance in the time of a pandemic. So it's closely monitoring the activity of people who have been exposed to someone else who is infected with the virus. So if we can go to the next slide. So like I said, we're only focusing on contact tracing today. And some of the key concepts by the CDC of using this tool is to trace and monitor contacts of infected people, notify them of their exposure. It supports the quarantine of contacts. It helps ensure the safe, sustainable, and effective quarantine of contacts to prevent additional transmission. It expands staffing resources. Contact tracing in the United States is going to require that states, tribes, localities, territorial establish large cadres of contact tracers and using digital tools. So this adoption and evaluation of digital tools may expand and reach efficacy of contact tracers. So here in this diagram, if you can notice how place is also tagged and it's monitored to explain how infection moves from an individual to where that the community that that individual comes from and who is also at risk in that community. We can go to the next slide. All right, so this diagram also shares how infection moves from primary contact to a secondary contact at another place, and then to a tertiary contact. I want to note that, like in the context of US exceptionalism, looking at an imported case, we start to think of things coming from elsewhere, and to keep in mind that an imported case can be a tertiary contact in the United States. This model is foundational in stating that a threat exists outside of the community, which follows this logic of othering, which also parallels Trump's announcement as of yesterday, suspending immigration to safeguard American jobs and defending the country from the pandemic, calling coronavirus the invisible enemy. So all of that, the languaging that's being used here. And then when we look at privacy concerns, last week, Apple and Google announced how they are working with across the world with governments, health organizations to share location data or Bluetooth to assist with contact tracing of people who may have come in contact with COVID positive individuals without knowing. Also, other app developers like Dimagi in San Francisco, they're testing a digitized workflow to support with contact tracing and monitoring people. So it would identify like the recent contacts and then work with the public health department to notify those. And then it would work in ways to give them constant updates of how are you doing. And so daily communication with them. And it states that there is like, we are asking for consent throughout this communication, but these are the new tactics or the new tools, I should say, that are being used in contact tracing. And additionally, like if in Massachusetts, they're taking the more traditional role of contact tracing of just hiring 1,000 people to be trained and go and do the phone call interviews and following up with patients. And so that's where we're at currently in California as well. So we can go ahead to the next. So Harry's actually going to give us a history of contact tracing now. Thank you.
Yeah, thank you, Jennifer. Actually, can we go back to the last slide? I just have like a quick introduction to do. Everyone's able to hear me. So I wanted to just pause on this slide because I think it's important to reiterate why a case needs to be made for thinking about history and context in relationship to contact tracing. And I can say personally, I had not heard the term, I'm not in public health, I had not heard the term contact tracing before a month or two ago, despite having been subject to a contact tracing program in Massachusetts because of a STI that I had contracted. With a name to it, I realized, I had a personal history with contact tracing and realized it to be a consistent tool of public health and state public health. Like all tools, they're invented for certain uses, and regardless of how recently, they have histories. So following these histories can show changing, persisting uses of these tools, what logics they employ, how and why and what context it was developed and used, how they have changed, and also importantly, I think for us, like how they've been resisted and contested. I want to emphasize the last point because the coalition has, and we'll go over this in my slides, inherited and continue the political struggles of other political and activist organizations and coalitions. And as one of the recent zines that Palestinian Youth Movement and Baby Anarchists put together, genocidal logics endure and reform during the coronavirus pandemic, and resistance and insurgency with work persist too. So I'm ready to go to the next slide. Just wanted to make a little bit of a case and start with a quote that gives like the cleanest cut breakdown of where contact tracing originates. I'll just read it. Developed in the 20th century for managing syphilis outbreaks, contact tracing involves asking diagnosed individuals to reveal the names of their sexual partners so that they may be tested and treated if necessary. The practice is best suited to diseases that are curable and highly contagious. This is from the book, Trevor Hopp's book, Punishing Disease, which is about the criminalization of HIV, and particularly pertinent there at the time because the infrastructure for contact tracing that we have inherited today was laid out during HIV/AIDS epidemic and continues to be for a disease that it was not relatively well suited to. So we can go to the next slide. And I'm taking us back, so we're gonna start like early 20th century, late 19th century and move forward. And you might ask why. I mean, we've been consistently identifying and know why structural inequalities, anti-Black, white supremacy, heteropatriarchy continue to kind of like structure how this pandemic manifests. And the early 20th century is a time in which like that was being reorganized in relationship to disease. And it's important to think about germ theory, which is the theory that microscopic organisms like viruses can lead to disease. While it's been around for a long time, that science really solidified in the late 1800s and early 1900s. And the takeaway here for us is that I think germ theory troubled the credibility of the visual. That is, that disease can readily be seen on the body, and cases like the well-known asymptomatic typhoid Mary created anxieties in the US about being able to discern and to develop ways to discern between and manage healthy and unhealthy bodies. Who is healthy, who is not. This coincides with concerns about bodies positioned as racialized, as we've said, both internal and external to the United States. Fears of passing among those, not being able to discern a racialized body. It's not uncommon to hear racialized bodies be rendered other through metaphors of disease, and indeed scientific health research uses the language of race to make sense of the unhealthy. Because of this uncertainty, new tools were required to complement quarantining, spatial segregation, for those who were not, that could not be spatialized. And so we need to think about how this is positioned in our laws and how this structures kind of state power. Should come as a note, I mean, it's not a surprise that racial logics are encoded into our law. National Quarantine Act of 1978, first law that gave the federal government the power to quarantine for the first time. In particular, it imagined threats solely as coming from the outside. That contact tracing diagram speaks to that, and allowed for indefinite detention of those who were potentially ill or exposed. And other contemporaneous US Supreme Court cases gave the federal government power to bar immigration entirely. That should resonate today. And the Immigration Act of 1903 explicitly barred entry to people, quote, afflicted with a loathsome or with a dangerous contagious disease. This also coincides with empire and public health as a kind of war. These kind of political and public health imaginations manifested themselves through imperial war, both at home and abroad. While the ways in which public health was used as a tool of colonial management and genocide and extermination in both internal and external colonies, constitutional cases that granted the state new powers imagined public health as a kind of war. Again, we can see that in the rhetoric in Massachusetts, like, we need an army for contact tracing. The Supreme Court case that gives public health authorities emergency police powers imagine public health workers as soldiers, quote, who were similar to soldiers, quote, at risk of being shot down in his country's defense. And so we can see early surveillance regimes like contact tracing emerging in this context, in which state power is multiplied, reworked, and then contested, which we'll get to in the next slide. I just want to attend to the image to talk about these overlaps, that this is an image from the 90s of people, an ACT UP protest of HIV positive Haitian immigrants that were being detained in Guantanamo Bay. So you see these overlaps of different kinds of regimes of power in the United States that collaborate on these kinds of, during quote unquote epidemics. We can go to the next slide. So just thinking about HIV, AIDS, and anti-surveillance resistance. This is the moment in which resistance to surveillance to manage HIV is noteworthy and is something that we have inherited as organizers. So this quote from Che Gossett speaks to AIDS activist groups and anti-prison organizations responding to the prison and medical establishment, as well as advocacy for immediate implementation of standards of care. We can go to the next slide. And I'll move quickly. I know I'm an Aquarius who, once I get on a roll, it's like, I just keep going. HIV, AIDS, and anti-surveillance resistance. So you see here, like, technologies of, new technologies of population management. And so as it became understood that people living with HIV were surviving much longer, the public's perception of PL-HIV, people living with HIV, also changed. They became seen as viral vectors, potential infectors, an inherent threat to society. And that meant that the state and public health and private corporations instituted new kinds of ways to track and manage those bodies. And this takes place in, as I've said, like overlapping wars that we continue to work against. Particularly the war on drugs, a racialized and class and police enterprise project, intensified and escalated AIDS epidemic through zero tolerance policies, mandatory minimums, and creating unsafe, vulnerable conditions that often, as it does now, discouraged people from getting tested because of criminalization for being seen as positive, as being a potential threat to civil society. And the last thing I'll say for this slide is that contact tracing is one of the methods that was used to track the spread of the disease of HIV/AIDS. And governments had wanted to institute contact tracing data aggregation that was in name-based systems, whereas activists proposed that states adopt anonymous code-based systems. There's more to say about that. I'm happy to talk about it more, but the thing to know is that, like, we hear this rhetoric in the news about, especially Dr. Fauci, as being a certain kind of savior, in part because of his work during HIV/AIDS. We need to remember that, like, HIV/AIDS resistance, organizations doing resistance was what got shit done and continues to get shit done. We can go to the next slide. And then the last thing I want to say is, like, what futures does this set up for us in terms of organizing? Where does this leave us with contact tracing? And there will be future meetings on this. It leaves us with entangled surveillance apparatuses. And I mean that in a couple different ways. That the way contact tracing is being framed by states and by think tanks is that these are entangled with syndromic surveillance, which is often involves different kinds of predictive qualities, predictive algorithmic programs. Sentinel surveillance, oftentimes overlapping with what's called hotspot policing or hotspot care. I was thinking of like Predpol and Operation Laser, something to be said for the overlap there, which is about cost reduction. And it's about thinking about the snapshot in time, communities that are considered to be high risk areas. And we know to be wary of these high risk, the rhetorics of high risk, and actually how that entails expansions of anti-Black, racialized, gendered, classed logics and policing. And that's the last thing I'll say. I mean, I'm happy to talk about, again, this is a context for what we're operating in and have been operating in. And it opens new questions for me for like research that I am continuing to do on the CDC memorandums of understanding that will continue to contribute to the project that we all are working on together. So I'll leave it there. Happy to talk more in the Q&A. Yes, to Mina.
Hi. So how contact tracing has been discussed has really rapidly evolved in the last few weeks. It went from being kind of discussed as a potential strategy to now being a core component being rolled out across the country. And public health departments are calling on leading public health experts, organizations, and institutions to support these efforts. And in the current narrative, and within that current narrative, they largely have done so and have really emphasized and described contact tracing as urgent, imperative, and critical in the current context. And however, a concern is that there's really been no critical dialogue of the ethical implications this can have in the short and long term across communities. And to the next slide. At the same time, we're also seeing blanket requests being made by leading health equity experts for more data, and particularly in specific, a recent call for data to be managed by the CDC. But what's not being discussed is how these data will be collected, by whom, and for how long, and how they are intended to be used, all of which are really critical questions to be raised, ideally would have been raised and thought through before these efforts were rolled out. But you know, from a public health perspective, contact tracing can then really interfere with the field's stated goal of improving, ultimate goal of improving the lives and conditions for all. And in fact can, as we're seeing it, you know, play out, can in fact work in synergy with the same structural factors that are driving the social and health inequities we're facing. And so on the one hand, you'll have Partners in Health, who is leading the efforts in Massachusetts, saying that contact tracing will be conducted in a loving and compassionate way towards communities. And then you have the director of the CDC saying that it's going to be very aggressive, kind of like a block and tackle approach, which really leaves us questioning what this really will look like and the implications these have for communities across the country. Next slide. But what is being widely discussed is this like a overwhelming attention being paid on the who will be conducting the contact tracing and the emphasis on a workforce shortage, which has resulted in the, as Harry had mentioned, the recruitment of an army that's required, which is including community health workers, students, as well as the National Guard. And but what's missing within the conversations on the workforce is training, how they will be trained. The recent studies that are coming out is that the training for contact tracing looks very much like our already fragmented healthcare system, and then in that there is very little coordination, oversight, a lack of evaluation components being considered, as well as no community input. And so the latter two being absolutely critical for ensuring community health and well-being, but are both omitted from the current public health dialogue.
So, so we were going to end on, thanks, Nina, for that. We're going to end on just kind of talking again about where we're at in regards to opening up California, right? So we spoke earlier about Gavin Newsom's plan and the 6 points that he has, and some of us have to start thinking, and I really appreciated Harry's use of the algorithmic ecology, because we have to start asking ourselves, where are these plans coming from? Who is funding these plans? Who is thinking of these plans? And so a report that was released in March, late March, by the American Enterprise Institute, it was entitled The National Coronavirus Response, A Roadmap to Reopening America. Now, for those, and I'm not myself very familiar with American Enterprise Institute, but have become more familiar with them now, but they're very much a right-wing think tank. Many people who have been fellows, many people who have been a part of Bush and Reagan's administration have been active members of this institute. So they have, and particularly Scott Gottlieb, who has been pretty prominent in the media lately as a physician discussing this roadmap, has also worked in partnership with Johns Hopkins Institute. So these two places, we need to start thinking to ourselves, who are they, what is their history, and how do they move? But essentially they have a 4-phase plan into opening up the country. And we are basically in phase 1. And this is exactly what, when I was trying to figure out, was California being influenced by this plan, it was very clear that California is definitely following in the footsteps of this plan. And so again, it makes us realize, okay, this is coming from a very right-wing think tank, and predominantly because the motivation is to open up the economy. And as we're, having these conversations, and we have all been having these conversations, we realize that the solutions right now that have always been the solutions of what we've been saying all along, that we need housing, we need healthcare, we need food, we need green spaces, but this roadmap is particularly just focused on how do we deal with COVID? how do we deal with the people who have COVID, right? And it fails to, in any part of the report, talk about the disparities that existed prior to the crisis. So that's really important for us understanding what this roadmap means in us moving forward. So the phase 1 is basically slow the spread, which is what everybody's been knowing, where we need to stay at home. But the bigger things within it, in phase 1, is again, this kind of increased capacity to test, but also building data infrastructure for rapid sharing of results, right? So now we have data, now we're talking about sharing of the data. And then another point that I thought was very interesting, and just kind of reiterating what I said before, is case-based interventions rather than community-based. So again, the othering that needs to happen, like who has COVID? Who are these people? We need to find them. We need to make sure that someone is quarantining them, that someone is enforcing that quarantine. Who are these individuals? Instead of looking at the structure of the larger structure that's even supporting folks. And again, they talk about hospital capacity, that it's addressed, right? That there's enough PPE, that there's enough bed capacity, that there's enough ventilators. But, as a frontline healthcare provider, I can say very clearly that that has always been an issue. Maybe not the ventilators, but not having enough beds, not having enough staff, hospitals being at capacity, and you can speak to any healthcare provider that works in an acute care setting in a hospital, and that it is not uncommon for hospitals to shut down because we are at capacity. So this is not a phenomenon of hospitals all of a sudden not being able to hold people. That has been something that has always plagued hospitals before the pandemic. And then lastly, and what we want to unpack and keep understanding more is implementing a comprehensive COVID-19 surveillance system, right? So this is the expansion of the public healthcare system in regards to COVID, and what kind of new technologies, algorithms, data collection, data sharing is going to happen. And the last, 4 phases or 3 phases are basically kind of the solidifying of the surveillance apparatus, of testing, looking for partnering with pharmaceuticals, and then basically the last step is rationing who gets access to treatments and rationing who gets access to vaccines. But I think one thing that, and this is just from information that I've received as being a healthcare provider, it's very interesting to hear physicians start to talk about what's available as far as treatments, as far as studies of what treatments can be used. And when we think about vaccines, on who is going to have access to a vaccine if and when it ever does appear. And it's very clear, and I'm a nurse in East LA and Boyle Heights, that I have physicians from that area very clearly telling me that they have, in these kinds of crises, have often not been able to access certain kinds of treatments and medications that they've needed for their community. And they believe it's predominantly because of what community they're servicing. And I think, is there one more slide, Aman? So, and this is just, again, I thought it was really important that basically it's just, that surveillance system, it's the diagnostic testing, it's finding therapies, and again, it's the rationing of who gets access to those therapies and who gets access to the vaccinations. And I think what's also really important, again, is just to reiterate that Johns Hopkins University is working in partnership with American Enterprise Institute. I think, is there another slide, Hannah?
No, thank you. That's just wanted to post it up there. And I don't know, Pete, if you are unmuted, can you say hello? I guess you're not. So I have to maybe go back because.
Hello.
Okay, you're there. My brother.
Just unmuted me, or I think someone did. Oh,
Shakir did. Okay, awesome. So Pete, now, just listening to a whole lot of this, I mean, that's a lot. I mean, there's a lot of information that we just shared, but I think sometimes it's also critical that while some of this information can get dense, but it's important for us to unpack it because it impacts our lives on a regular basis. So just Bita said something earlier about two things I wanted to, lift with you and see what your thoughts were. Like, one of the patterns of the disease are expanding. So that's some of the unknowns that we are walking into. And Bita, I do want you to talk a little bit more after this as well. But then the other piece also is, Pete, that given the rush and the sensationalism that is going on, how, people are getting sick. There are other sicknesses and other ailments that, our communities face, particularly communities in Skid Row. So access to healthcare is now being sort of, in a way, being redefined in this moment around this whole, this public health crisis. So talk about, like, so as to how do you see that, and where is our fight, and what is our defense there?
So I think, so just first and foremost, thank you everyone who's presented. And while the information is dense, the information is important, right? It's important for us to share our denseness, and hopefully over the next hour to interrogate that denseness in a way that makes the language more accessible to folks who might be a bit confused. I would say a couple of things just from the outset, Hamid, just based on all of that conversation. I would just say US genocidal tendencies continue to flourish, right? And the same targets, and when I think about targets in the United States, of course, Africans in America and Native Americans continue to be primetime targets, even in our explanations of the COVID-19 four-step process. Even the language around stay at home, right? The assumptions that are entailed in stay at home, particularly in a city like Los Angeles, when we have so many houseless folks and so many more folks who will become houseless as a result of this pandemic. I think also when we talk about contact tracing, we also have to move back a bit, right? Because I think contact tracing is one thing, but how about those folks where there's no communication? There's really no tracing because there's really no humanity in those communities, right? And so, we think about no communication, right? We're just now beginning to get data. And then, data can be skewed, either way it's skewed, but we're just now getting data in terms of the real impacts in various communities. And folks are really trying to hold on to that, right? Because they don't want that to be a rallying cry and an organizing cry. And in the histories and the herstories, when I talked about US genocidal tendencies, we cannot forget the Tuskegee syphilis experiment, right? Where people, they were traced, right? But they were traced in a totally different way, right? They were traced as guinea pigs to figure out how non-treatment would affect them, right? Black men and women, right? Or then we would think about James Marion Sims, right? The whole body of gynecology was birthed, right, on his slave master fucking tables and Black bodies, right? And so we even in these conversations have to be thoughtful about some of those whose humanities still aren't considered, won't be considered, and are never worthy of compassion, right? And so I just think oftentimes we'll jump ahead, and I know we're talking about histories and herstories, but sometimes we got to pull it back a whole lot more, right? Now, moving forward a little bit, it's really interesting right now. So I know folks are listening to the headlines, and you hear that the mayor of the city of Los Angeles and the county says they're going to get 15,000 hotel rooms for nearly 60,000 houseless people. However, at the pace that they're going, they've only been able to get 1,243 hotel rooms at a pace at about 40 per day. And if they were serious, and they're not, about getting 15,000 hotel beds or hotel rooms for houseless people, they could accomplish that in about 2021, right? But all of that being said, right now, in order to even qualify to be able to get into those hotel rooms, you have to be in the homeless management information system.
Wow.
You have to have a case worker. You have to be deemed as vulnerable on one of their various vulnerability tools. Vulnerability tools, which, by the way, Department of Public Health know and understand is skewed because of a couple of questions around mental health, right? And the steadily known fact that African Americans simply don't like talking about, we're getting better, but really don't like talking about our mental health histories, right? And so from the get-go, even when they talk about help being present, you have a homeless management information system, you have a vulnerability index that's skewed away from Black folks, and you gotta be in contact with the system on day one. And this is, and then I'll be done on it, and this is on top of, oftentimes when we're talking globally about vulnerabilities, we talk about elders, right? Older folks being vulnerable, and that age being around 65 or so. However, the average mortality rate for houseless individuals is 51 years old, right? And so our whole models are skewed. And at the same time that our models are skewed, there is this engagement of data, right? That's being held for very different reasons, from my honest opinion. Not for reasons that are to help folks, but reasons a far cry more sinister.
Don't mute yourself. I got to follow up on that. So you know, obviously what we are seeing, and this is something like, you know, the numbers are staring it in our face about the disproportionate impact on the Black community of COVID-19. You know, that whole tragedy in St. Louis, all around. But you know, just the sheer reminder that 100% of deaths in St. Louis happened to be Black when that report came out. And now this whole language emerging, or not emerging, but the language of, you know, this vocabulary around, you know, the narrative that is being built about predisposition, around susceptibility of Black bodies to this disease. And then, you know, the whole if you will, sort of, I'll use the word reintegration, you know, more than anything else, as a way of hygiene, right? So now we have this triangulation of almost this pathology that is being created. The demonization of a community is very much there, which leads to the further criminalization of our communities. So now let's set ourselves in Skid Row where we are, in a sense, like, what does it really mean for our communities? So what is, how are we thinking ahead as to how these things, and as you are speaking to that, could you also, like, what do you see on the ground as to just the normal afflictions and ailments that people have, that what is happening to that?
I mean, and I can be, I'll strive for brevity here. I mean, the things that we're dealing with now are ancient, right? They're the ancient tools of white supremacy and the ancient tools of structural racism, right? And so what you're finding is a large community in bad health as a result of economic apartheid, right? As a result of discrimination, as a result of racism, quite honestly, right? That's the only way that, you know, the life expectancy of folks in 9013 and 90021 is 14 years, 15 years different than Beverly Hills, right? There's no other way to explain that. And so what we're seeing are the tragedies, the long-term tragedies of that in real time. The other thing that's happening, so for the last 2 days, and you know, this is when you know, it's not about you, it's about them. So for the last 2 days, we've been anchored in Skid Row for 25 years. We've been calling for testing, right? Culturally sensitive and appropriate testing after engagement with the community. You think anyone reached out and called us and asked us how that shit is done? Of course they haven't. But for the last 2 days, there's been 14 ambulances 20 patrol cars, a medical tent, white dudes in full hazmat gear attempting to test folks in our community. Do you believe folks are going to that goddamn truck to get tested? Of course they're not, right? Of course they're not. The push that we have is the push that we've always had, right? I don't believe that our organizing will change as a result of COVID-19. It will just get more sharp, right? We'll just highlight it more, but it's not going to change because we're still going to organize for the things that we've been organizing before: economic justice, gender justice, housing justice, right? Racial justice. We have to continue to organize for those things, but we also have to look across the shores, right? When I'm thinking about testing in Africa and other places, that has got to be made important here, right? Africa will not be your petri dish either, and Africans in America and our allies are going to have to lift that cry.
Thank you, Pete. So I'm just gonna, Bita, I'm gonna go to you, but before I do that, let me just unmute you, and if you want to unmute yourself now. So right after we get a comment from Bita, we're going to open it up to really now engage in a collective conversation. What we'll do is to see if we can unmute all and see if that works, because typically people have their music going on, background noise going on, so if people can start to considering muting themselves. And in the meantime, also send us a message in the group chat if you have a question or a comment. And then also, if you're on the phone, you can also text it to 562-230-4578. 562-230-4578. So Bita, my question to you was that you mentioned that earlier, which I just asked Pete as well, like patterns of the disease are expanding. I mean, that seems pretty ominous out there. So can you talk about that a little bit more?
What I was referring to with that was kind of, if at the day before this whole thing, whatever happened, let's say that there's a day for it. And if any of us had been asked, what do you think is going to happen? We would have said, this is what's going to happen. Right. And so exactly as we predicted, right, from the very moment, because of how we understand white supremacy to work and to structure both the science, right? And this is getting back to the history that Pete was bringing up in terms of medical experimentation, and specifically the role of, kind of torture and violence against Black bodies to get that data, to get that information, right? Both in terms of that history, we knew it was already there. And then we also understood that we were completely operating within segregated health systems, segregated geography, segregated schools, right? And so that within this history, right, the settler colonial history, what we call racial capitalism, being the foundation of this country, and then even like, because Pete has, put out the call that we should, keep going back to 1492, right? When as soon as they decided that the rest of the world was something in order for them to study and therefore control, right? In whatever way could maintain their power and privilege, we are living the legacies of that. So all of us, with this consciousness, knew that this moment would look the way that it is. Given what we see on the ground, given everything, all the work that LA CAN has done, Stop LAPD has done, all these different abolitionist organizations have done, we knew that this moment would look like this. So when I talk about the patterns of disease expanding, I'm talking about the patterns that I feel the most confident to talk about, which are the racial health disparities. Even in some of this testing data that has come out, and also fatality data that's come out, you'll see in these same places, there'll be these major disparities, right, by race. And at the same time, 50% of that data is still unknown because they're not collecting race and ethnicity data. Does that mean that we're gonna then think, oh my God, maybe it's not us who's dying, right? No, I think we definitely know who's dying, right? But at the same time, when you, I wanna take a pause here, because while we knew these patterns of disease were expanding, I think the part that it's not that I'm surprised to see, but that is very interesting to see at this moment, is the way that data gave confidence to these folks in Huntington Beach, right? These quote unquote, these liberators in Chula Vista and different parts of the country, that now think that you know what, white supremacy's health is at risk because I'm being asked to protect another group of people by staying inside. And just right there in that example, you can also see how the data is completely like misleading, because even if, regardless of what you do, these systems and structures are still not going to support the people that we need to be supported. And I think right here is an important point that I want to bring up around, and I know many of us are critical here, you know, like there's this like expression in like surveillance that, I think it's like, in order to know what needs to get done, you need to measure it. Like you don't know what to do unless you measure the problem. And that gives us like a false sense of like, if we give them the data, somehow the system is going to change. And everyone here knows that that's also not going to happen. And I think this contact tracing conversation is also deflecting us from that. Like in what world, right? Or let's actually just say in this world, every country that's getting a handle of this understands that the health of its population is crucial to being able to have any chance of having the least amount of damage from this thing once it's over, right? Like we were just put it in those terms. But here in this country is the only place it's like everybody who needed the hospital, no, you got to stay out. And instead what we're going to do in the hospital is we're just going to brace ourselves for everybody else who needs it. Well, that entire population out there that needed you, what is going to happen to them, right? And you see that still, I mean, and you know, this is where this whole solidarity piece comes in handy in terms of like understanding like the public health system. Really this entire conversation, and public health is its own kind of set of tools, and it's kind of, you know, in a little bit of a, has to rethink around this issue right now. But this whole conversation has also been driven by the hospital, right? And by like the healthcare workforce that works in that hospital, which is one of which has already failed people before. And now in this context is also because of the way that it's trying to protect itself. And I really want to distinguish that from protecting the workers, because the workers are not protected by this hospital either, right? That how the hospital is trying to protect itself is creating all these collateral consequences.
Great, thank you. So at this point, we're gonna try to unmute people and see if that works. But there's a question here that do you think that they're heading towards mandatory vaccination, and what can we do to stop it? So let me just see. Okay, can people start hitting their mute buttons? Let's see if this will work. Mute. So. Oh my God, there. Okay. Oh my God, I know. I've seen this. Okay, if people can, well, okay, I'm gonna have to mute it if people can't unmute themselves. So. Okay, hold on a second.
A lot of heavy breathing.
Yeah. All right. So that seems like, is this workable for people? Is that okay? Are we good? Okay, cool.
Good.
All right. So let's open it up. Let's see, like, you know, where people are at, what they have, what they're thinking right now, and if there's any.
You can add it to Karzem.
Yeah, can you please mute yourself, please, if you're speaking in the background. Okay, so now let's open it up. Let's see where people are at, what have we heard, and what's our strategy, and what are we learning, and what's our defense, and as we move forward.
I was briefly gonna respond to, like, do you think they're heading towards mandatory vaccination?
Sure.
I don't have an exact answer for that, but in the roadmap that we shared during like the phase, so we're currently in the phase 1 of this like reopening America, like what that looks like, and it's a lot of like surveillance. But in the case of a vaccine, like because there isn't one, that's where they would be using like the population level immunity serological surveys that they're now spreading out to see who's immune, who's already been asymptomatic. But I don't know to what extent it would become mandatory. And I don't know if our epidemiologist wants to share on that.
I mean, when I see this mandatory vaccination question, it just reminds me of the equity trap, which is like kind of guiding this whole thing. And we've talked about this along the way, you know, that, my, folks from my discipline, immediately testing. And now like, wait a minute. So wait, who's getting tested? Who's not getting tested, right? These all were equity issues. And we're running into this problem with vaccination at the same time, in the sense that if a vaccine is developed, we're also going to be like, make sure you give it to Black and Brown communities, right? We don't want our communities to be left out. At the same time, if it becomes compulsory, then we're going to be like, wait a minute, like, why are you forcing this thing on us? So that we're, and so vaccination for me then also becomes one of these issues that distracts us from I think those core principles that that Pete was saying that we have to push for, like before we can even like get to the contact tracing conversation, we really do need for them to understand that we see that you're not trying to optimize health to begin with, right? Because once again, any modality or any treatment that comes in, at one point we're gonna want to argue that if you don't give it to us, then you're somehow being you're not following the best principles of equity. But on the other hand, as they're giving it to us, we're gonna be like, wait, what are you giving to us? Mm-hmm. Right? So, that's what I have to say about that. Okay. So I'm gonna maybe reach out to some folks who are on this call and see, because they have a certain level of expertise that, so there's a lot of technology that is being proposed. And Ken, if you can unmute yourself, I'm gonna go to you for real quickly. So we're hearing about like Bluetooth technology, we're hearing about smartphones, we're hearing about various other forms of tech that is being deployed, these partnerships between Google and Apple and various other folks. So talk about that a little bit, just as to what you are seeing and what is that landscape looking like to you out there?
Yeah, and I think, so I think one of the important things that I think I really appreciate being with you, a co-founder, with Pete, et cetera, is I think the coalition has always had a kind of an internationalist perspective, understanding that the weaponization of technology usually begins in places like Iraq, Afghanistan, Kashmir, Puerto Rico, et cetera, and then finally it lands here. So I think that as we look at this globally, it's interesting seeing things like Germany proposing something like a QR code or some other type of technology tracking, so that the economy, and it's wonderful to follow up on all the wise words, the knowledge that's been shared, because just thinking about how the real important here, which become clear, is that restarting the economy will always be superior under capitalism to the health of the general population, especially of people who live in precarity. So that's one of the other things when we talk about the technology, and even when like talking about things like vaccinations, is the idea of who are the people who cannot say no. There will be people who will be able to say no and enforce their will, kind of like the anti-vaxxers do. And there will be some people who will be subjected to scanning and invasive technology in certain ways. I think the last thing I want to highlight is the dependence on technology that has not been developed with a shared political analysis. I think the left is bereft. We don't have technologies that we've really developed. So we're married to Google and to Apple as a primary mobile operating systems. And when we agreed to those products, they have in their terms of service, licensing model that we agree with them, gives them so much power that they could change what they're allowed to do as a condition of our use of their devices. So I think that it's a constantly shifting landscape. I would encourage us to look at the international tracing that is going to be done, and expect all that to trickle in here under the guise of, and I think that's one of the brilliant assembly of tonight's presentation. I think that there is this strong continuum between the language of public health to national security. And as we start to go more and more into the language of national security, we'll see more and more invasive technology pushed upon us, just like we did after 9/11. So I think for the sake of brevity, it's probably where I'll leave that. Thanks, Hamid.
Yeah.
Can I hop on that for a second?
Please go ahead. Go ahead.
Okay, because I mean, one of the things where my continued research is going with technology is really thinking about like how privacy is being framed, and we can look to see how privacy is being framed in marketing from different private tech companies, from states themselves, from universities in their white papers. And one thing that I want to say is that, and this gets a little bit back to kind of the HIV/AIDS organizing, is that a lot of privacy is being determined by the fact that that quote unquote names and identifying information is being stripped away. MIT's privacy app talks about that. Stanford's app talks about that, as does Google and Apple. That would seem to fulfill a lot of the kind of demands that we have inherited, that different kind of organizing, anti-surveillance organizing, activist organizations have inherited. But what I also, the other side of that is that actually identifying information like names is not something that's necessary to perform population management. Like, we know that things like police hotspotting and medical hotspotting actually operate quite fine by determining geographical zones that are based on other characteristics that we would say are quote unquote private, that we say are not revealing any information. The other sides of this is that the actual language of giving your information away, so say on the MIT app, I think it is, like if you are found to be positive for COVID, what they call it is you give your data to charity. So your revealing of your data is a charitable data donation to the public sphere. And so what we need to be thinking about is like, these corporations are trying to answer the question of this is private, when actually like they are determining privacy in a very limited way that doesn't have anything to do with how race, gender, class are looked at through technology. And the last thing I'll say is that there's already papers about how, if we're concerned about advertising, about how advertisers can set up Bluetooth monitors in their storefronts to see who is passing by. There's already papers about working with CCTV so that a CCTV camera could integrate a Bluetooth receptor to pick up whatever Bluetooth code is being used and determine your location. So, you know, thinking about where the technology is, we need to be thinking about how they're talking about privacy and really think about, whether, you know, more private data or more open source data is the answer.
Right. I mean, I think this is, yeah, go ahead, Ken.
Yeah, so I'm gonna say like, I would say like the work, I think this is a perfect time to put things together. So the coalition's work with the Our Data Bodies project, I think really provides, and hopefully I'll try to put a link in the chat to that. I think it provides a perfect entry point to when we're talking about privacy. Because I think that like really in a nutshell tells us who has it, who doesn't have it, and what the historical context, and how that's an organizing doorway into organizing. I think this fight is, as a technologist, this fight is not a technology fight. This is an organizing fight. This is a people power fight. So I would say like making sure that we have these conversations, and it's really great to see these conversations or series of them labeled as power, not paranoia, because I think too often we have so little control over the services that we use. So I will share that, and even when we move out of the realm of like hard technology. So I'm in New York. I had COVID-19, made it through, signed up for some of the plasma donation programs. Rockefeller called me today and we reviewed the terms, and I was like, all right, let's go ahead and do it. But it's interesting because it's effectively, so they can do whatever they want with my plasma. So my plasma isn't, when I finally get around to donating that plasma, because they want me to go to Princeton, longer story, but when I donate plasma, I will probably not have the knowledge of knowing that it actually went to a person. It could go to MIT for research, which MIT will then sell to one of the many offshoots that their shady ass professors have on the side. So I think even there, let's put these fabrics together and identify that it is a nuanced fight, but it's a fight that I think, using the skills that the coalition has used in previous campaigns, it's about exposing these motherfuckers and organizing against them.
Yeah, I mean, I'm almost thinking, and whether it's a correct analogy or not, that if we are, because having been there on the front lines, thinking of the post 9/11 moment, can folks?
Some nice frogs out there.
Ben Lawson.
Yeah, I'll just do that. That if we are in that moment, a post 9/11 moment, where this expansion of the national security police state and the surveillance state is just all over the place, and then obviously now, and what became of it, just the third-party data brokers and various other things, and now a few days ago we saw Predpol, the company which creates these predictive algorithms, getting into the mix as well, which of course we are right now in the process of looking at it very closely, of what that means, and how they, and how there's so much money to be made out of a lot of this as well. So in a sense, the challenge really is, and one of the things we saw post 9/11 out of that whole investments was the uselessness and the wastage that came out of that. So now what we are seeing is, again, these money coffers being opened up by CDC getting $500 million to set up a surveillance apparatus, everybody else getting these monies, Google and Apple getting these monies, everybody's in the run. So the long-term adverse impact on the community, and I'll go to maybe just Bita and Jamie with that question, that drawing this parallel between what we saw post 9/11, I mean, there are these estimates. There was a report that came out, which was safety at any price, which basically identified, and this was in 2012, which the US Senate did that on the expansion of the surveillance industrial complex. And they saw that through FEMA, almost $40 billion had been given in the expansion of the surveillance state. And when the US Senate, another committee did an audit of intelligence gathering as a result of it at fusion centers, their response was that intelligence gathering was useless, irrelevant, duplicative, potential violations of Privacy Act protections. So now, rather than the infrastructure that you all have been talking about, which never existed, and to invest at, now we are going into this policing our way out of the problem. So any thoughts about that, Bita and Jamie?
I mean, I think that, it just that continuing of that racial logic that, whatever we're at war with right now, and that right now we're at war with the virus, like all the other wars that have come before it, both like, whatever, whether it's the war on the criminal, war on drugs, war on illegal, war on terror, whatever we're calling that now, war on virus, that it's distracting. And in the same ways that those things were distracting, and the ways that like power, specifically white supremacy, is reshaping, reshifting, and rethinking about how it's going to now think about, its next like 10, 20, 30, whatever years. Like we are at that moment again right here. And so like, if there's a lesson to be learned from this moment that you bring up, Hamid, it's that like, we cannot get distracted again. We cannot get distracted again and thinking that somehow an app is going to be a replacement for community health. And we cannot be distracted in thinking that an app, and a community health worker, right, that you hire, that stays in their house to call you, right? Especially given what, Pete is laying out as the dirty divide, the technological divide, right? The ridiculousness of all the mitigation strategies that we have put out, right, from public health. Every single one of them from the beginning has been one that completely leaves out major groups of people, right? And so that like when we are been doing that from the beginning, how is it that we honestly think that contact tracing in our hands right now is going to achieve like any sort of like outcome of which would even be close to whatever it is that we're calling an abolitionist vision, right? So I think that we like, you know, on the one hand, I know we have to monitor, I know we have to break down, I know we have to dismantle, but we also have to keep really making it very clear how distant this is from the vision that we're talking. And right now, from a discipline, like whatever, in terms of talking about it from a public health perspective, all the ways that talking about equity and racism within our field were incomplete, right? All the ways that we thought that maybe it was historical and it kind of shows up right now, but if we frame things as public health crises, then we're gonna get people to care, or if we put an MD on the front line, then it's gonna somehow get us someplace. Like, none of that is working. None of that has ever worked. And so that, you know, this becomes a moment for us that while we're monitoring them, that we also have to think about what does that community health system look like? Why is it that we literally cannot go out and touch people, take their temperature, right? Walk them to like secure and safe housing, make sure that they have food, right? And what I'm asking for, and I think, and then the other part is that we cannot also then be pushed to the side and made to think that that vision that we're having is like, you know, it doesn't fit in the world. And, you know, for example, like the model that keeps being brought up is in Cuba right now, right? And if we think about how in Cuba, population of 11 million people, 9 million have been screened. You think a country with that extreme amount of sanctions on it is out there testing 9 million people? No, screening 9 million people doesn't mean testing people. So they are also in a situation, apparently like the United States, where we don't have tests, like we don't have resources. You know, obviously the roots of those problems are dramatically different. But if you have a health system, you have actual doctors, which are community doctors who live in the community of which they are supposed to be taking care of the people because they are not separate from the community, right? Because they're already there. Like that kind of screening and that kind of support would have been, you know, is the only equity conversation that I think that we should have right now.
Right. Thank you.
And, you know,
Yeah. No, that's definitely. So any other thoughts before I go to Jamie? Just please go ahead, and if you want to do your hands up, raise your hand, or, you know, just however you want to do that. So Jamie, I want you to put on your organizer hat now from the Stop LAPD Spying Coalition. And of course, like, you know, with PredPol and the dismantlement of PredPol today, but now again, PredPol coming back and offering this sort of roadmap to identify. So that's one moving part that we see. And then the most recent announcement that came out that Trump has now signed on Peter Thiel and Palantir to be central for all the data collection, and what would that look like? So just if you can briefly just kind of, just for folks who may not know about these things, but or on this call, but just give us a snapshot as what your thoughts are about that, and what is our organizing looking like?
Yeah, well, I think that, you know, one of the biggest things that I think the coalition really tries to and continues to unpack is this whole idea of data gathering and data as a tool of liberation. Because I think that, you know, building off of what Bita was saying, is that we have to realize that, you know, all these different mechanisms, whether it's through a contact tracer, whether it's through syndromic surveillance, whether it's through you getting tested, all this data that they're gathering is kind of given to you with this kind of dream that you're going to get the resources you need once they find out. And that is the biggest problem around when we think about algorithms, and Pete had mentioned also vulnerability indexes, like for unhoused folks, they have the coordinated entry system. And, you know, these indexes and these vulnerability indexes, these risk factors are all supposed to, you know, put whoever is most in need in contact with the resource, right? And the thing is the resources aren't there. As we know through history, resources have only been given to us when we have demanded them, when we have gone directly after them. So I think that in kind of believing that more testing and, you know, having all these contact tracers out there is going to somehow give us resources, I think that's, we have to rethink that. And then another piece that I was thinking about is this movement towards technological solutions really begins to automate our relationships with each other, where no longer, as Bita was saying, are we talking, are we connecting, but everything is being done through telemedicine, through some kind of Bluetooth thermometer, through, for example, I'm doing self-monitoring right now, so there's no nurse that's necessarily coming to visit me, checking in with me. I get a text message, yes or no, do you have a symptom? And I send that text message back. So I think we have to think about the utility of all this kind of technology within the context of a system that is hostile towards us. So that technology is only going to replicate that hostility. And I think if we see it as that, then when we come back to our organizing, what is so important right now is really exposing this. That is one of the victories that we need to have right now, is to demonstrate what the stalker state is, to demonstrate that as we say healthcare is the solution, we need to simultaneously be exposing that it's also the problem, that it's also a part of the national security police state. And this is how our information moves to kind of help people remove that kind of veil that somehow these technological solutions are actually amplifying us or getting us towards something good. Where I think, as Pete had said, it comes down to the basics of what we have always asked for. You know, housing, food, gender justice, healthcare, you know, all those things are really where we should be focusing our attention. And we really need to spend time exposing what this system is. Because I think a lot of folks don't realize that syndromic surveillance has been happening, right? I mean, Bita, in some of the conversations that we've been having, behavioral surveillance has been happening through public healthcare systems. Hotspot mapping of diabetics has been happening. But how many physicians do you know that, and I mean, speaking as a nurse, that walk into a patient's room, the patient starts to give them the context of how they ended up there, and the doctor's just like, well, I know what kind of bacteria it is it the right antibiotic? Are you having any more symptoms? Is your foot getting better? Are your lungs getting better? Okay, I gotta go because I don't have time for that, because I've got so many other people to see. So I think really, and then kind of going into what PredPol and what Palantir are going to do, and what they've historically always done is criminalize. So as PredPol is out there announcing itself and trying to jump in on the market of technological solutions, basically they want to be utilized. And we have to imagine, though, that even if it's not PredPol doing this, that the data that's going to be shared with law enforcement is essentially going to be to enforce quarantine, to enforce stay away orders, and technologies as far as CompStat, hotspot mapping is all going to be about finding those communities or finding those individuals that are positive, that do have high risk factors, and patrolling those communities more. So we have to really kind of integrate, is this technology actually pushing us towards a system that we want, a system that we want to replicate, or is it getting us further away from that? And if it's getting us further away from that, then we need to demand that healthcare workers and the public healthcare system actually is talking about it.
Great. Thank you. Thank you. I saw JG's hand go up. If you can unmute yourself. I don't know if you can, or maybe I can.
Can you hear me?
Yes, please.
Hi there. Thank you all so very much. My question, I was hoping to hear from some public health expert on the panel. Like, one of the things I mean, you've brought up the 9/11 parallel, and I think, you know, in the wake of that, we had our, you know, our Patriot Acts and our Guantanamos, and it was sort of easy to stake out a very, like, a position that was fearful and against, you know, so many draconian things that were happening at that time. Like right now, I'm finding that my community is so paralyzed and just baffled about what to do. I see an inherent sort of contradiction now when you bring healthcare into it, because especially on like such a large, you know, epidemiological level, everything is so dependent on top level decision making. So how do we confront this tension, and how, like, what can we do on a community level to actually come up with our own decisions about how to do this, and open up space to be critical of some of these state measures without being labeled crazy MAGA people. That's it.
It's such an interesting time for us right now that our challenging these solutions puts us into that group, right? But it's not unique, and it's not a unique time either. I think that to your question of like, what can we do, is that we have to take a step back, and we have to breathe, and we have to think about the full health, the holistic health, right? And in that ways, then how do we put pressure on the system to not let one part go because it's frantic with another part? I think on a very basic level, that would go very far, because it means that we're taking care of the people that we're taking care of. And then on the second part, I think that as a community, we have to, if there's something immediate that to watch and to push back against, it would be, and I think, I don't know if Pete, you said it right here, or Hamid, when you were talking about the opening of testing in downtown, that like, if opening up the testing is displacing more people and making them pushing them more into poverty, right? Then how is that a solution? So I think that instead of coming from like you're using this data or you're lying, is to take a look at the solutions and be like, what are the collateral consequences of these solutions? Like, what are the other things that are, now how else has risk been increased? One of the ways that we are trying to get people from the public health world to appreciate, right, policing during COVID and all this, is to talk about the added risk that policing will add, and to what body does that add, and then thinking about the COVID risk and adding it on top of it. And I'm not saying that we should only talk risks and make arguments and risks, but we can also then look at the tools, like the solutions that they're putting forth, and being like, what are these other consequences of it? And at the same time, why have you forgotten to give us basic health care? Why is that okay if everything that is, all the pieces of information that are coming out, the only secure piece of information that's coming out is that people need to go into this with their best health possible? Why would it make sense for you to take away that? So yeah, that's,
Thank you. So in the last 15 minutes, I think it'll be great for us, and I want to bring Pete back into the conversation. Let me just look for Pete's mic here. But before I do that, there was a note from Mike Edie, I hope I'm pronouncing it right, to some kind of an informal contact between the coalition and people, organizations up in San Francisco. Can you just briefly share as to what you were talking about, Mike?
Hi, sure. Can you hear me okay?
Yes, and keeping it brief, please.
Sure. Yeah, last name is Eid. I'm an immigration attorney in San Francisco. I live in the Mission District, which has a very heavy immigrant population. I just want to kind of play off what Jennifer Alvarez said about DiMaggi, and what I think Ken Montenegro said about the weaponization of tech and how it comes home. DiMaggi is being mentioned over and over here in San Francisco as the sort of main player that's going to roll out their app. And they're doing this in conjunction with the city and county of San Francisco, as well as UCSF, the University of California at San Francisco. So I've been doing some research on DiMaggi. I've filed a number of FOIA requests. Those are being processed. I haven't got any information back yet. DiMaggi has done work with, contracted with the World Bank, the Gates Foundation, World Vision, and most distressingly for me, USAID, the United States Agency for International Development, which has at least over the course of a few years provided significant funding to USAID. A quick Google search on USAID, Cold War, CIA, this sort of thing, what they've done throughout Latin America and the Caribbean, as well as across the planet, is truly distressing. And talking about, the weaponization of tech and tech coming home inevitably, to me, that's where my primary concern is. It's frightening. So that's kind of what I'm focused on. I'm in contact with organizations and individuals here. I'm just hoping to maybe establish some informal contacts with your organization, which I found on Twitter. I just joined Twitter a month ago. I try to steer clear of all that stuff. Just maybe so we can exchange information. Oh, Damaji's in San Francisco. Damaji's in LA. What are they doing here? What are they doing there? Just try to
Great. So definitely we should connect offline, and we should do that. So reach out to us on Twitter, Mike, and we should definitely follow up on this. So, so Pete, let's just coming close to wrapping it up. You know, there's a lot that was discussed. There's a lot that was talked about. There was a lot about the stalker state. There's about the impact, about obviously how this continuing conversation that we continue to have about how race, poverty, and suspect bodies are impacted and how they're surveilled, and what is happening, and we see that firsthand every day. But there's also an opportunity here to, you know, just how and what that solidarity and what that movement building could look like. So talk about, like, you know, what are some of the thoughts that come to you as like, you know, being out there, like what are some of the opportunities in this current sort of crisis that we're looking at?
Yeah, I think a couple of things. I think the first thing, I'm just sort of on a daily basis overwhelmed by the numbers of folks who are stepping up and saying those who are selected, I was going to say elected, but those selected leaders are failing us, and we need to figure out who has a plan and invest in that plan. And so this spirit of mutual aid and generosity in this moment needs to be sort of captured and transported into the power building and organizing space. That's one. The other thing that's really, really interesting, and I like when Bita was talking about, so, and you as well, Hamid, what are the opportunities? Well, I think there are a number of opportunities when we hear from the government, and not that any of these things are perfect by any stretch of the imagination, but just the fact that they're talking about stimulus checks, right? When we're talking about certain types of wages, when they're talking about commandeering properties, right? When they're talking about all of these things that could have been investments made and things that we've been calling for decades, now that they can roll them out as if they have a blank check, I think there are opportunities for us to think about, all right, so in the long term, what does a long-term investment in housing look like? What does a real investment in healthcare look like? Because we know when you need to muster up the resources, you can find them. Never mind the fact that if they give us $1 trillion, they're going to give their capitalist buddies $3 trillion, right? We still got to deal with that. But the fact that they've just exposed themselves should lead us to think about what are those big asks that we should be organizing, or those big demands that we should be organizing towards right now. I think one of the things that's happening, and we have to make sure, and webinars like this is a great space to make sure it doesn't happen. There's a lot of space around mutual aid, right? And there's lots of arguments why mutual aid is important, why it's not important. I argue that we have to figure out a balance. We have to take care of our people right now, but we also need to figure out how this moment can be leveraged for some of the longer term fights and things that we've been organizing for decades, right? So on Skid Row, COVID hits, the information hits, all charitable food donations leave the community. We have to step in, right? We have to step in and feed people. But at the same time that we step in and are feeding people, we're also organizing. We're also intervening in litigation. We're also trying to pressure judges to make the city and the county and the state to do things differently, right? And so I just want people to be mindful that we need to, like, strategically, we need to take care of our people, but we also need to figure out how to leverage this moment for some of the longer term fights. And also, this is just the last little piece, also, if we don't find the right communication, the right language, what will happen is that selected leadership will co-opt that latter piece, right? And so they'll want to talk about our long-term housing plan. They'll want to study it. They'll want to hire consultants to do all of those things as a way to not have to deal with the now, right? And so there's organizing and there's strategy conversations we need to have, not on Zoom for sure, but we need to figure out how to balance the moment for the long term.
Absolutely. That's when we switch to Mumble and do an audio only sort of an encrypted conversation. So most definitely. Great. So with the with a little bit of time that we do have left, any other comments, people? There's we had about 85 people. We're down to 58, so it's a smaller number. Any other comments? Any other questions folks may have in the last few minutes?
Yeah, I have a quick question.
Sure.
My name is Houston. For everybody who doesn't, I guess most people don't know me, I'm curious what some people are thinking about the role that, or rather, whether we should be mobilizing behind specifically sort of data ownership as an idea. Obviously, I think there's a kind of data abolitionist perspective, but I guess I'm wondering whether it would be sort of politically and strategically useful to start to think about, okay, perhaps what we should be thinking about here is like how can all of this data sort of be sort of recaptured and made account and sort of have be sort of democratically controlled, as compared to sort of, if it's going to be collected, as it is going to be collected, it sort of seems to be collected, to sort of allow it into this kind of like rent-seeking, profit-seeking structure, rather instead to see if there would be some way to sort of essentially exercise like democratic control over that. I'm curious to see if this is something that people find interesting at all.
Well, I have some thoughts about it, but maybe I'll let someone else see if we got other folks on the line, because I come strictly from a data abolitionist frame.
Right,
so,
right, I know.
Jamie, or even we have Andrea as well from New York. So anybody, and I think I saw Ruha down there too. But either one of you wants to just take this? Okay.
I mean, I'm happy to say a little bit about my feelings. Is that, sorry, am I talking on top?
No, please go ahead.
Okay. I mean, for one thing is that, like, I think this idea of data ownership is oftentimes the rhetoric that companies and governments already deploy to say how data is used, that it is that is still our data, that it is stored with them, but it remains ours and a part of kind of like a democratic vision. And I think we've been talking about, when organizing this, like, does data ownership entail actually any kinds of changes with how data extraction occurs? Like, do we really, I think Jamie had said this in one of our meetings, that do we really want to have power over a system that continues to extract data out of our bodies? And so I think in terms of data ownership, I can see the strategic reasons. There are people who talk about digital loitering, which gets out of the kind of public-private property thing that is actually kind of like a more, I don't know, illegal concept for dealing with data. But it's a question of, like, do we want to have control over systems that are going to continue to be extractive and productive of kind of like racialized and gendered violence? And I think that's where the question leaves me. I don't know if others have thoughts on it.
Yeah.
I do think, though, as a solidarity piece with whatever we're calling like the public health, the health system, or just that workforce, is also understanding that data is central to everything that they do. And whether we agree with that or not, like, to take it from them right now would cause a major crisis in that field. So I do think that there's something around, us talking about this and figuring this out, because, we started off this whole series, like, thinking about public health as both an ideology and a set of tools, right? But we also acknowledge that if, you know, we want a say on the political system that actually would, this ideology, that would shape this ideology and that would have control over these tools. And of course, there's a whole history of, you know, of all the ways that public health itself needs to be decolonized. But there's also a way in which, as the system right now that provides these physical needs, right? And technically, you know, kind of these psychological needs, right, that we have, how do we expect this workforce to operate around this? So, I mean, and so I bring this up to say that however we're thinking, wherever we think we're going to end up, we also have to phase ourselves into that. And that, you know, this might not be in partnership with the system, but this might be in partnership with the workforce that is also having an awakening of what does this system think of them? You know, how it claims that the workforce is not disposable, but the workforce is also disposable to it, you know? Right. So, you know, that's what I want to say about the data.
No, I appreciate it. So last minute or so, I think, so what would the coalition probably be working on? I just wanted to, I guess, let's see. Well, yeah, so this is something that we're going to be, just to kind of leave folks with this thought about the stalker state when it comes to data. I mean, I think to the point of data, that all things given equal, if we knew that, you know, okay, what the intent was, like, you know, just coming from that it will remain at one spot. But when you're looking at the movement of data, and when you look at it, the immense, you know, just landscape of where data moves, then it definitely creates a lot of apprehension about, like, you know, where is my data going? So even data ownership becomes this whole process of, like, you know, I mean, am I just as Harry was saying, am I really the owner, or am I just a facilitator of that movement of data? So I think that's the real sort of a catch-22 that we have been placed in. But to wrap it up, folks, this has been really, really an awesome conversation. I just really want to thank Jen and Mina and Harry and Jamie and Bita and Pete for all the knowledge exchange, for the wisdom that you all shared. And I think for the Stop LAPD Spying Coalition, we remain committed and obligated to our communities as to how we continue to keep on mapping as to where this is going, how do we continue to organize, how we continue to bring this conversation to our communities. And today we got rid of Brett Poll. Well, tomorrow there's going to be another campaign, so we rest and then we move on. So our next webinar is going to be next Tuesday, which is the 28th, which is going to be same at 6 o'clock. The primary focus is going to be exactly what we were talking about, data-driven policing. So it'll be really good for us to see, like, you know, where data is moving, how is it's being used by the police, where does the stalker state, you know, just move with our data. So with that, thank you all very much. Stay healthy, stay safe, and much love to everybody. And we'll talk to you soon. Thank you. And this is going to be this is being recorded. It's going to be uploaded on our website in the next couple days, along with the PowerPoint as well. So you'll have access to that PowerPoint too. So www.stoplapdspying.org. Thank you very much, and we'll talk to you soon. Adios.